All right, hi everyone. I hope you guys are having a great day. So in this video, we're going to be talking about issues related to psychotic disorders. We'll discuss this in a second, but when we say psychotic, we're basically saying out of touch with reality. There could be other disorders that we could discuss here, but we're going to be primarily focusing on schizophrenia today. Also, activity 11 will be discussed in the lecture video. Remember that activities need to be at least 200 words long and your own original work. Now, with activities 11 and 12, I mentioned this in the last video, you do get 2 drop grades for activities. So I'm going to keep your top 10 activity grades. Each one of those activities is worth up to 10 points. So if you've gotten 10 points out of 10 points on the first 10 activities, then you already have the maximum of 100 points from activities. In that situation, it would not benefit your grade to do activities 11 and 12, although if you would like to do them, of course, you can. But if you've missed an activity or two, or not gotten full credit on an activity or two, then this is a chance for you to earn some of those points back. If you have questions about whether or not you should complete activities 11 and 12, feel free to send me an email. I would be happy to answer those questions. If you decide to use activities 11 and 12 as your drop grade, just don't respond to them, just don't answer them, just leave them blank. And then when I do the grades, I will automatically drop those 2. I'm going to be automatically dropping everyone's 2 lowest activity grades. So if you have any questions about any of that, please let me know. Otherwise, we're going to go ahead and get into lecture. Alright, so as I said, today's lecture video is going to focus primarily on schizophrenia. Now, technically this lecture is on psychotic disorders, but when we're talking about psychotic disorders, most of the time we're talking about an individual having symptoms of schizophrenia. Schizophrenia is not the only time when a person might experience psychosis. Psychosis can happen as a result of a brain injury or maybe substance-induced. So we talked during our lecture video on drug use about how something like, for example, LSD or even potentially marijuana could produce symptoms of psychosis. But basically, psychosis is a loss of contact with reality. Now, there are many different ways that this can present itself. Basically what we're saying is a person probably has changes in their ability to perceive and respond to their environment. Now, some of the disorders that we've talked about have had, pretty much all of the disorders have had an impact on your functioning. But psychotic disorders have a very significant impact on functioning. An individual who's having a psychotic episode is likely to be having a lot of problems in relationships, in work or school, really in general health and taking care of yourself. So there are many things to consider when we're talking about psychotic disorders. Now, some of the symptoms that you may see, and we'll talk more in detail about these as we go throughout the lecture video, would be hallucinations and delusions. These are some of the symptoms that are considered not exclusive to schizophrenia, but much more commonly found in schizophrenia than in other disorders. Some of the other symptoms we'll see could be found in depressive disorders or in anxiety disorders, but symptoms like hallucinations and delusions are relatively unique to psychosis. A hallucination means that you're having a sensory experience without anything there to produce that. So you're hearing something, but nothing is producing sound. Or you're seeing something, but what you're seeing is not truly there. Now, it is difficult sometimes to ask clients these questions to try to get information about these symptoms because to them, it's not a hallucination, it's reality. And so if you ask a client, well, do you see things that other people don't see? The client may not be aware that other people don't see the things that they see, or they may not trust other people when they say that they don't see them. So this is a difficult question to ask, but you might say, has anyone ever told you that has it ever seemed like maybe you were experiencing something that other people weren't experiencing, and can you tell me a little bit more about that? You may also see delusions, which are beliefs that are not realistic. Probably a lot of individuals have some delusions to a certain extent. We're not all 100% logical and 100% plugged into reality all the time. But we're talking about beliefs or thoughts here that are so distant from reality that they are very deviant or very different from what you see in other people. So as far as the prevalence rates, schizophrenia affects about 1% of the population. It is estimated that about 2.5 million Americans currently have this disorder. So when you're talking about a prevalence rate of about 1 in 100, this disorder is not one of the most common, but it's not entirely uncommon either. What we see is that individuals who have schizophrenia, because of the severe nature of their disorder, they might be a little bit more likely to be identified, whereas there may be some diagnoses that are just not recognized. So the costs associated with psychotic disorders are enormous. There are personal costs, of course, to a person who is suffering. They're having distress, they're having dysfunction. There is also a cost to society because of things like health care bills, that kind of thing. Individuals who are suffering from symptoms of schizophrenia are at an increased risk for death by suicide, as well as physical illness, because people who have schizophrenia may not have access to good health care, or may not be willing to or able to engage in those self-care behaviors. Now, when we're looking at who is at an increased risk for schizophrenia, we do tend to find symptoms of schizophrenia more in individuals who are living in poverty. There are a couple of different perspectives on this. On the one hand, you might say that the stress of poverty causes the disorder. So a person might have a genetic predisposition towards schizophrenia, and then the stress of living in poverty might be the thing that triggers those symptoms. Whereas a person who was not living in poverty may not have those symptoms. On the other hand, though, it would also make sense that an individual who has symptoms of schizophrenia might then go into poverty, and this is called the downward drift theory. So if an individual is suffering from a loss of contact with reality, that would certainly make things like going to school and maintaining a job very, very difficult. And so there's probably some truth to both of those theories. Now, there are some disorders that we see more commonly in men or more commonly in women. We have roughly about equal numbers of men and women being diagnosed. We do see a little bit of a difference here, so the symptoms seem to start a little bit earlier for men, whereas they tend to start a little bit later for women. Now, this is an average. It says the average age of onset. Of course, that means there will be some people who have symptoms earlier and some people who have symptoms later. It is very rare, but not unheard of, for children to develop symptoms of schizophrenia. So, although I don't know much about it, I think TLC might have done a special a while back. I think I remember hearing about a young girl who had been diagnosed with schizophrenia. But it's most commonly going to pop up during the 20s, although you might see some symptoms kind of earlier before the symptoms become severe enough to warrant a diagnosis. It also differs based on marital status, so it is most likely to happen in individuals who are divorced or separated. So once again, there is the question, is it that the symptoms are caused by a divorce or separation, as in the stress of ending a relationship causes the symptoms to come out? Or is it possible that being in a relationship with a person who has symptoms of schizophrenia is difficult, and so then the divorce or the separation might be caused by the symptoms? So probably, once again, some of both. So there's a list of symptoms here. Of course, the criteria change every time the DSM changes, and so we just have to be aware of that and be flexible with that. I'm sure the next version of the DSM is already underway. But working with the DSM-5, it says individual has to display 2 or more of the following symptoms most of the time or much of the time, so not necessarily all the time, but a good amount of time for at least a month. So we already talked about delusions and hallucinations. We might also see things like disorganized speech, so it is very hard to carry on a conversation with the person who is having a psychotic episode. Very abnormal motor activity, which could be excessive motor activity, but it could also be something like catatonia, which involves a person basically not moving for an extended period of time. And catatonia can sometimes involve people positioning themselves or being positioned in very odd ways that look very uncomfortable, and then staying that way for a certain period of time. Now, as you'll see, a lot of these are considered positive symptoms, but negative symptoms also exist, and I'm going to differentiate between those two in a second. But a positive symptom is basically the addition of something that is problematic. So adding to a normal functioning a delusion or hallucination. But we can also have negative symptoms like taking away something that we would expect to normally be there. So for example, you would expect a person to have a certain level of communication, or a certain level of motivation, or a certain level of desire to be around other people. And so we can see some of the things you would normally expect not being there, and those are called negative symptoms. Alright, so schizophrenia produces many clinical pictures. So if you look at the criteria on the previous page, if you really only need a couple of those to get a diagnosis, there are many different combinations. The actual symptoms themselves and the nature of those symptoms can vary greatly. So for example, with hallucinations, there are many different ways a person can have a hallucination. They can see something, they can hear something. Sometimes people have tactile hallucinations where they feel something. So maybe it feels like there's something crawling on your skin that's not really there. So there are many different potential clinical pictures here for schizophrenia. So some clinicians have actually argued that schizophrenia itself, because there are so many different ways that it presents, might actually be a group of disorders. And then maybe we should have some subtypes. And so previous versions of the DSM have maybe thought about this a little bit more, about having subtypes of schizophrenia. So maybe more of a paranoid schizophrenia or a catatonic schizophrenia. Maybe there is some research to be done on some grouping together specific clinical pictures. Now, as we said, you have positive symptoms and negative symptoms, but you can also have psychomotor symptoms, symptoms that are related to the way a person moves. And those psychomotor symptoms are, as you're going to see, probably due to the cause, or one of the causes of schizophrenia, which is going to have to do with some abnormalities in neurotransmitters that impact both psychological symptoms as well as a person's movements. So as I said, a positive symptom means we're adding something unexpected, something dysfunctional, something that's causing distress. These are pathological excesses. So a few examples of these, as we've talked about: delusions, faulty interpretations of reality. So a person believes something that is so far from reality that it is just too deviant to be considered typical. Now, a lot of the delusions have to do with things like persecution or being controlled by others. So this is where a person might have that paranoid kind of perspective that people are trying to get me, the government is trying to control me, everyone is out to hurt me, that kind of thing. But they can also have things like delusions of reference, where maybe they feel like someone is putting information into their brain. They're not really sure about where something comes from. Delusions of grandeur, where a person might feel like they are a celebrity, they are a very important, very powerful person, so they might feel like they have powers that they don't actually have, or feeling like they can control things that they can't actually control. So these are beliefs about reality that are just not accurate. You can also have disordered thinking and speech, and so as I said, it is really difficult to carry on a conversation with a person having a psychotic episode. They will have these loose associations where they will jump from one topic to the next topic, and it's extremely difficult. Even within one sentence, one paragraph, they are all over the place, very hard to follow. But they may also do things like making strange sounds. They may make up new words that you don't know the meanings of, or maybe saying those same words over and over again. And so it is very difficult, and it takes a high level of patience and skill to interview an individual having psychotic symptoms. So some examples here. Loose associations. This might be what you might hear from a person having a psychotic episode. The problem is insects. My brother used to collect insects. He's now a man, 5 foot 10 inches. You know, 10 is my favorite number. I also like to dance, draw, and watch TV. Basically, there's one little thing in a sentence that reminds them of something else, and so they jump to that next sentence, and then the next sentence has a brand new idea. And so this can look like a person who is under the influence of a substance. So you need to rule that out as well. But a person having a psychotic episode might also have some of these made up words, might actually start repeating these words over and over again, might make strange sounds or strange rhymes. Maybe they feel like they have to speak in a certain pattern. So these are just a few examples of positive symptoms that you might see. Now, probably one of the things you think of most when you think of schizophrenia has to do with sensory changes. So if you've watched movies, and Hollywood doesn't always do a great job of showing what psychopathology looks like, but if you've seen movies, usually what they play up is this change in a person's sensory experiences. So you might have heightened perceptions. With a heightened perception, there really is something there, but you're feeling it or experiencing it in a much more intense way than other people are. So maybe there really is a noise going on, but that noise is driving this person insane, and everybody else thinks it's normal. It's not causing them any problems, but it seems to be heightened. So a noise that we experience might seem much more annoying or might be very loud to a person who's having these heightened perceptions. Also, hallucinations happen when there's nothing there. So with a heightened perception, there really is something to see. You're just seeing it in a different way. There really is something to hear. You're just hearing it in a different way. But with a hallucination, there's nothing to see, there's nothing to hear, there's nothing to feel, and yet a person is experiencing it as if there were. Now, it makes for really good movies to have visual hallucinations, but actually auditory hallucinations are the most common. So the person feels like they're hearing something. So perhaps they feel like a voice is speaking directly to them, maybe giving them orders. Or they might feel like they are overhearing conversations that are going on between other people that are not actually going on. But it could involve other senses. Tactile would be touch, right? Somatic, interestingly, we talked about somatic disorders, so a person might have like a pain hallucination, things like that. Really, any of your senses can be impacted by hallucinations. And then, in addition to that, a person might also have inappropriate affect. Now, when you hear the word affect, we're talking about emotions. So a person might be feeling emotions that are unsuited to the situation. So perhaps there was just a tragedy or a death in the family, and yet the person seems to be laughing and seems to be happy, that kind of thing. So the person's emotions seem to be inappropriate. So in addition to those positive symptoms, we can also have negative symptoms. These are pathological deficits as opposed to excesses. So this means something is missing that we would normally find in another individual. Negative symptoms can include a poverty of speech, a couple of different things. This could be a person who does not speak much at all, or it could be a person who speaks and yet their speech has very little content to it. So once again, it's going to be really difficult as the psychologist to get information. When you're trying to interview a person, if they're not talking to you at all, or they're talking to you but there's very little meaning in what they're saying, then obviously it's going to be really confusing and really challenging for the psychologist to work with this individual. In addition, we might see pretty much a removal or a flat affect, a removal of your emotions. So we talked about how you could have a positive symptom of having excessive emotions that are inappropriate, but you could also have a negative symptom of having no emotions whatsoever. So when you hear flat affect, that means a person's just showing no emotion, and maybe showing no emotion over a substantial period of time, even though there are things happening that would normally trigger emotions, whether those be positive things or negative things. The person's emotions don't really seem to change. So they show less emotion, also tend to not have the same kinds of social interactions that other individuals have. And so they might have things like avoiding eye contact, not showing any expression, really a monotonous voice that doesn't change, just like their emotions are pretty flat, their tone of voice is pretty flat, as well as anhedonia. Now, I told you guys that some of the symptoms of schizophrenia are shared across other disorders, and then some of them are more unique to schizophrenia. Anhedonia is one that we talked about with mood disorders. It's a loss of pleasure or enjoyment.
So, if anhedonia is a key aspect of mood disorders, but also shows up during psychotic disorders, you might start to wonder, can these two things coexist? And they can. You can have individuals who are having a mood disorder with psychotic features. So maybe the primary issue seems to be depression or bipolar disorder, but it's severe enough to be causing some psychotic symptoms. So yes, these two can overlap. In addition, some other negative symptoms are things that we don't usually see in a person with schizophrenia that we see in a typical person. A loss of motivation. So a person who has been diagnosed with schizophrenia is likely to have an inability to start or follow through with things. So maybe the person doesn't have goals for themselves, maybe long or short-term goals, or if they do have those goals, they don't really feel much push to try to reach those goals. They may feel ambivalent. The word ambivalent is sometimes misunderstood. It doesn't mean that you don't care. It's more like you're conflicted. So if you're trying to decide right now whether or not you want to go to grad school, you're not ambivalent in that you don't care. No, ambivalent means you don't know what to do. Maybe you feel ambivalent about what should I do with the rest of my life. Obviously you care what you're going to do with the rest of your life, but maybe you feel conflicted. So we may also see social withdrawal here, where individuals are unwilling to be around other people or have no desire to be around other people. And then as a result of that, a person who is not spending time around other people can also see their social skills be substantially lessened as well. But you can imagine why a person who has these symptoms might want to withdraw from other people. So if you're having hallucinations and delusions, you might feel like you can't trust other people. That might be part of the content of your delusions, is that you can't trust other people. And what if you've tried to share what you're experiencing with other people and they have not been receptive to that, they've not understood that, then that can also make you less likely to want to spend time with other people. So I can see how the social withdrawal can develop, but that's also going to make it hard on the psychologist to develop a relationship with the client. So in addition to those positive and negative symptoms, we can also see psychomotor symptoms. And as I said, this is probably due to some of the issues that cause schizophrenia, as we're going to talk about neurotransmitters. So people with schizophrenia sometimes experience psychomotor symptoms like awkward movements, repeated grimaces, so facial expressions, odd gestures. And so sometimes these people take on catatonia, which is just a stupor, basically a person who's extremely rigid, perhaps, or a person who gets into a certain position and does not move for certain periods of time. And so one of the difficulties when you're working with a client who has schizophrenia is that you're trying to understand why this behavior is happening. Is this behavior happening because of something that's neurological that the person can't control? Is this a behavior that they find reinforcing in some way? There's something that feels good to them about taking on this particular position. So psychomotor symptoms might be something that you see with a client with schizophrenia. Now, as we've said, schizophrenia is the average age of diagnosis is somewhere in your 20s, a little bit earlier for men, a little bit later for women. But sometimes those symptoms might develop during those late teenage years, and then after a few years of having milder symptoms, then the symptoms might become more significant. So we see 3 phases where we typically cycle through these. So during a prodromal phase, we have a person start to experience mild symptoms. Now, if this is happening, as the kind of typical trend is, if this is happening the first time during the late teenage years, then parents might not know what to make of this. Maybe they start wondering, is my child using a substance perhaps? Or is this stress? Or is this peer influence? But you start seeing some mild symptoms. And then after that, we progress to an active phase where the person is having a psychotic episode. The symptoms become much more apparent and would then meet full criteria for schizophrenia. Now, most individuals, after a period in this active phase, will have a residual phase. So after the active phase kind of ends, the person may return to those prodromal-like levels of mild symptoms. So you start with mild symptoms, you progress into a more severe active episode, and then after that, you got to go back to that previous level of functioning, more mild symptoms. Now, for some individuals, this may be the end of it. You may have this one cycle, but for other individuals, you may continue to have residual problems, and you may go back through these phases again and go from the more mild symptoms back into the more severe active symptoms back and forth. Whether your symptoms remain mild or go away versus becoming severe again depends on the stress, depends on the environment, depends on whether or not a person seeks out treatment. So each phase of the disorder can last for various periods of time. So sometimes these phases are very short and a person has an episode over maybe a week or so, and then they return to normal functioning. On the other hand, some individuals continue to have symptoms for years at a time. It's very hard to predict exactly which outcome will happen, but we do see that we have better results from individuals, first of all, who had better premorbid functioning. In other words, their level of functioning was higher before the symptoms came. So maybe this is a person who has more of a mild issue. Also, if the disorder was triggered by stress, that may be a little bit easier to overcome versus having the disorder triggered by something more biological in nature. So maybe a person has a predisposition, but the stress is really what put them over the edge. And then maybe we can do something in therapy to help the person be better prepared to deal with stress or to try to reduce the source of stress. And so then maybe the symptoms don't come back, or at least they don't come back as severely. Also, someone who has these symptoms start abruptly tends to have a better outcome versus a person who has these symptoms gradually creeping up on them over a period of years. Also, later onset tends to have a shorter course. So if a person develops these symptoms earlier in life, they usually stay longer. If you develop the symptoms later in life, maybe even perhaps middle age in your 30s or 40s, then a person might be less likely to continue to have issues later. And of course, receiving treatment as soon as possible is helpful. Where does schizophrenia come from? There are, as always, many different theories, but sometimes we feel like we've narrowed in on a particular most likely cause. And when it comes to schizophrenia, biological explanations have received the most research support. So we're going to talk about some biological things that are different in individuals who develop symptoms of schizophrenia. But what you should also know is that there's definitely a diathesis stress model here. Some people have a biological predisposition. Some people have a family member, maybe even an identical twin who has schizophrenia. And yet that individual does not go on to develop schizophrenia. So having the predisposition does not necessarily mean a person will develop the disorder. However, when it comes to things like schizophrenia, they are highly biological, highly genetic, so we would definitely want to keep an eye on an individual if we knew that person had a predisposition, so we could get them into therapy as soon as possible if symptoms were to show up. So when we're talking about genetic factors here, we do see that schizophrenia is more common when a person has relatives who have schizophrenia. And the closer your relationship biologically to that person, the more likely you are to develop that disorder yourself. So when we're talking about the general population having 1% chance, a first-degree relative has a 10% chance. And then that number would increase even more if we were talking about identical twins. So yes, obviously genetics play an important role, but once again, whenever we're talking about genetics, we have to keep in mind a shared environment. So not always, but typically a person is living with their first-degree relatives. So if you have a family member who is engaging in some of these behaviors, you might start to engage in those behaviors too, because it's natural for you to mimic the behaviors of other people around you. So probably there's some of both, but there does seem to be a strong genetic component. When it comes to twins, we found that if one identical twin develops the disorder, there's a 48% chance that the other twin will do so as well. Now, that's a very high number, but it could be higher. We're talking about individuals who have basically the same genetics, and yet only about 50% of the time does the other twin go on to develop schizophrenia. That tells us that the twin who is not having symptoms probably has a genetic predisposition, since their genetics are basically the same as their twin, but maybe there's something different in their environment. Maybe there's some kind of protective factor that they have that the other twin does not. Now, when we're talking about fraternal twins, once again, we're talking about twins that share the same amount of DNA as any other sibling pair. They just happen to be in the womb at the same time. And we do see an increased risk here of about 17% chance of developing the disorder. If one twin has it, the other twin has a 17% chance. But then once again, when you're talking about twins, I mean, siblings tend to be close, especially during those early years, but twins seem to be especially close. If you are a twin, or if you know people who are twins, they have a special relationship, and that special relationship may also play a role in addition to the genetics. Alright, so carrying on talking about the genetic relationship here, what about adoption studies? What if we take adults who have schizophrenia and we trace back their biological parents and their adoptive parents? So they were adopted as children, they go on later in life to develop the symptoms of schizophrenia. Were they more likely to have schizophrenia like their biological parents or their adoptive parents? Well, if you follow with what's going on genetically here, what we're saying is that the symptoms are probably going to be more similar to the individual's biological relatives rather than their adoptive relatives, even if they never met their biological parents. So a child is born to a parent that has schizophrenia, adopted by an individual who does not have schizophrenia, and yet that child, even though they have no contact with the family member that had schizophrenia, is still more likely to go on and develop schizophrenia later, which tells us that then the individual is not modeling it. They're not learning it because they see it. They're learning it, or they're having these symptoms because of their genetics, right? So, genetic factors. We know that our predisposition towards schizophrenia is highly genetic, but what exactly do your genetics do to you to give you this predisposition? So, there are two things we're going to talk about. We're going to talk about biochemical abnormalities, which have received some of the strongest evidence here, and a lot of the research has been here on neurotransmitters. But we are also going to touch on abnormal brain structure as well. So it says, over the past 4 decades, researchers have developed what we're going to call a dopamine hypothesis. Now, a hypothesis is a guess, basically, an educated guess. It is consistent with a theory, and it can be directly tested. So we have this idea that dopamine is related to symptoms of schizophrenia. So certain neurons using dopamine fire too often. We have too much dopamine, or the dopamine is causing too much of an effect, and that is potentially causing our symptoms of schizophrenia. Now, where did this theory come from? Well, like many of our theories, we stumbled upon it accidentally. What we found is that medications that reduce the impact of dopamine help with psychotic symptoms. So antipsychotic medications that are given to individuals diagnosed with schizophrenia, they work by reducing the impact of dopamine. And when a drug reduces the impact of dopamine and simultaneously reduces the symptoms of schizophrenia, it gives us an idea, it gives us some evidence to suggest that the dopamine might be causing the symptoms of schizophrenia. So these drugs were originally developed for allergies. A lot of the drugs that are given today, they're not given for the things they were originally developed for. But what we found is that the drugs that we now have labeled as antipsychotic drugs caused a Parkinson's-like effect. So when we're talking about the level of dopamine that a person has, Parkinson's disease and schizophrenia are on opposite ends of the spectrum. A person who has schizophrenia has excessive dopamine, or their dopamine is too active. On the other end of the spectrum, an individual who has Parkinson's disease, which involves, among many other things, tremor, those individuals don't have enough dopamine, or their dopamine is not active enough. So what we found is that with our antipsychotic drugs, if we gave them to individuals, they were inducing Parkinson's disease-like symptoms because the antipsychotic drugs decrease the effect of dopamine, and Parkinson's symptoms happen when dopamine is too low, which is potentially causing their shaking. So dopamine is related to a person's ability to control movement, and so we did talk about how there are psychomotor symptoms that are involved in schizophrenia, so it would make sense that there's some relationship between dopamine and schizophrenia. So what exactly does this relationship look like? Well, dopamine may be overreactive in people who have schizophrenia because they may have too many receptors. Now, how do you do research on an individual's brain? There are different ways to do it. Sometimes we can get the information we need from scanning, from an MRI, from a CAT scan. But sometimes we get the information we need from autopsy. After a person has passed away, if that person or their family had left instructions for an autopsy to be conducted, and we find that in individuals who had symptoms of schizophrenia, when we look at their autopsy findings, we do tend to find unusually large numbers of dopamine receptors. When your brain is flooded with a neurotransmitter, it has excessive neurotransmitter, your brain might say, okay, well, I don't know what to do with all this dopamine. I need to create more receptors for dopamine. And so this does have a strong, it's correlational, but a strong implication that there is a relationship between dopamine and symptoms of schizophrenia. So imaging studies have also shown this, right? Particularly high occupancy level of dopamine. So the dopamine is binding excessively with these receptors, and that could be potentially causing the symptoms. So on the one hand, drugs that reduce dopamine also reduce symptoms of schizophrenia. On the other hand, individuals who have symptoms of schizophrenia seem to have excessive dopamine, or at least excessive receptors for dopamine. So this is where our theory has come from. So researchers have also linked schizophrenia to abnormalities in brain structure, not just in the neurotransmitters. Although dopamine is important, we have this very strong dopamine hypothesis, which is not perfect, but it makes sense. But in addition to that, there may also be problems in brain structure. So if you look at those imaging scans, or if you look at autopsy, individuals who have schizophrenia are also likely to have some of these other abnormal brain structural activities or issues. So, for example, people who have schizophrenia may have enlarged ventricles, which is the part of the brain that contains fluid. And so maybe an excess of fluid, very large ventricles, which may be a sign of poor development or damage in related brain regions. Well, where do we find issues with the individual who has schizophrenia's brain? Well, oftentimes in the temporal lobe and the frontal lobe. Well, what do those lobes do? The temporal lobe is associated with hearing, and so this could be related to the auditory hallucinations that some people have with schizophrenia. The frontal lobe is where your ability to think and to pay attention is found. This is where your ability, like your personality, is found in your frontal lobe. And so individuals who have schizophrenia may have smaller temporal and frontal lobes. They may have less gray matter there. They may not have enough blood flow there. Now, the actual structure of a person's brain is highly genetic. So this, combined with an excess of dopamine, could definitely produce some severe symptoms. That's a theory, and we have a lot of research to support that theory. Now, this next theory, we do have some evidence to suggest, but this is really correlational, and it's just an idea that we have, so nobody panic here. Is it possible that symptoms of schizophrenia might be associated with exposure to viruses before birth? Now, this evidence is going to come from animal models primarily, and then correlations, which you understand correlations do not equal causation, but there is a relationship here. We see that individuals who are born during the winter months are a little bit more likely to have symptoms of schizophrenia. Now, I believe, I don't remember when they qualified winter months as starting, but I think it went through March, which I'm born in March, so this is me too. If any of you guys are winter babies and you're panicking, I'm right there with you. But the idea is that when a woman is pregnant, she may be exposed to certain viruses during pregnancy that could potentially impact things like brain structure. So a lot of the research here has to do with things like the flu, for example. Now, of course, there are many individuals who have the flu or are around other people who have the flu while they're pregnant who do not go on to have children with symptoms of schizophrenia. But there does seem to be a correlation here, that the stronger your exposure to certain viruses, then there's an increased risk here. Okay. As I said, this is circumstantial, so this is just correlational. This is based on some animal studies, not necessarily a reason to panic, but perhaps a reason to be cautious here. So we see that mothers of children with schizophrenia were more often exposed to the influenza virus during pregnancy, and exposed to it probably frequently and more severely than mothers of children who do not develop symptoms of schizophrenia. Once again, this is just a theory. I feel like there's a lot more research that we could do in this area, but I want to once again remind you guys that it's very difficult to do research ethically, especially when it comes to pregnancy. So it wouldn't be ethical to take women who are pregnant and intentionally expose them to the flu virus just to see what happens. And so this research is going to have to be done correlationally. All right, so we have some different theories about where symptoms of schizophrenia might come from. So this is a partial explanation, though. And we know this is a partial explanation because there are some individuals who have predispositions to schizophrenia. Maybe they have excessive dopamine. Maybe they have some differences in their ventricles or their frontal lobe or their temporal lobe. Maybe they were born in the winter. All right, don't panic too much about that. What we see, though, is that sometimes people have these issues and they don't develop schizophrenia. So this really seems to give us strong evidence for a diathesis stress model where a predisposition increases your risk. But whether you actually develop the symptoms or not depends on other things. Well, what other kinds of things does it depend on? Well, it's going to depend on other psychological issues. It's going to depend on the environment that you're raised in. It's going to depend on your protective factors, your social support that you have, right? So because we do have a strong, at least maybe correlational, but pretty strong evidence to suggest that there's a biological issue when it comes to schizophrenia, people have stopped looking into psychological theories as much. When there's good evidence that dopamine is the cause, then we might say, well, we need to focus on dopamine. We need to develop better antipsychotic drugs that reduce the impact of dopamine. And yes, we do need to do that. However, psychological factors are also important as well. So in addition to just taking on a biological model, we need to also be thinking about some other perspectives, some more psychogenic psychological issues, because some people have a predisposition and never develop those symptoms. So when we're talking about the other views, though, you have to be aware that these other views are not going to have as much support as the biological model. The biological model cannot be separated from schizophrenia, but rather the psychological, psychogenic models here could contribute to the biological model. Like in addition to dopamine issues, a person may also have some of these psychological issues as well. So the behavioral view here, oftentimes behavioral views have strong research support, but when it comes to psychotic disorders, it's not so much. But the behaviorists would say, okay, well, your behaviors happen because they're reinforced. So obviously, a person is somehow being reinforced for these symptoms that we would consider odd, and they're being punished when they engage in normal, typical behaviors. Okay? So, for example, if a person is experiencing hallucinations and delusions, then perhaps they would be reinforced for that. People would maybe give them attention for that or something like that. Or what happens if a person is just neglected? A person is not given that socialization that they need. then that person might start to seek out their reinforcement elsewhere. So maybe they propose that some individuals are not being reinforced for social activities, and as a result, they stop trying. I mean, if you don't feel like you're being reinforced for being around other people, then you might start to isolate yourself. And you might start to focus on other things and different things. And then when you start behaving in ways that seem bizarre, you might be then rewarded with attention. And so then you stop having what we would consider typical social behaviors, and you might start having more deviant social behaviors. So according to a behaviorist, it's all about reinforcement and punishment. There is some support for this, but this is at best a partial explanation. Although you can understand how a person's social withdrawal could develop that way. If a person is trying to have a relationship with someone else, but they're being punished because people don't understand their hallucinations and delusions and their experiences, so being around other people feels punishing, then you can see how a person might start to isolate his or herself. So it could certainly make symptoms worse. We may also have a cognitive view here, which would agree that biological factors are probably the issue in the beginning. A person has a dopamine issue or a brain abnormality that causes some odd symptoms, but then perhaps these symptoms linger or get worse because of faulty interpretations. So just as an example here, what happens if a person, because of a dopamine issue or a brain structure abnormality, has auditory hallucinations? So you're having symptoms because of biological problems, but then you start seeking out help from your friends, and your friends tell you, no, that voice you're hearing is not real. Well, an individual who's already having symptoms might take that as my friends are hiding something from me. My friends are trying to trick me. My friends are trying to make me think there's something wrong with me when there's not. And so because of that, the person might become paranoid about being around other people because they're afraid that other people are trying to hurt them or deceive them. And if the person starts to feel persecuted by other people, they may withdraw from the individuals that are around them and may spend more time focusing on the voices that they are hearing. So is it possible that the way that other people respond to an individual's symptoms might then make these symptoms worse? It's absolutely possible, but once again, this particular view has not shown as much support as the biological view, of course. But then there's also sociocultural issues. We do see that there are some differences in the experience of schizophrenia across different cultural groups. And so with sociocultural factors, we're trying to understand the environment that a person is in that might be potentially contributing to the symptoms, maybe making the symptoms worse, or even potentially causing the symptoms in the first place. Of course, a person's culture and society, it's very important. The people you spend time around are either going to be helpful for you or they're going to hurt you. They're either going to make your symptoms better or make your symptoms worse. So this is once again probably not what causes the symptoms to develop in the first place, but can be a factor in how severe the symptoms are. Now what I want you guys to be thinking about here is why it's difficult to work with a client who has schizophrenia. So first of all, for your activity 11, why might the treatment of schizophrenia be hard on the client? Think about the symptoms of schizophrenia. Think about social issues. Think about paranoia. Think about maybe difficulties in communication. Why would it be hard for an individual to seek help for symptoms of schizophrenia? But I also want you to be considering, on the other hand, why would it be hard if you were the clinician? If you were the one providing the services, why would this individual be especially difficult for you to work with? I want you to have a frame of reference for this because some of you may go on to work with individuals who have psychotic disorders. And so that's good work that needs to be done, but it also requires a certain skill set. So I want you guys to be thinking about why this is difficult both for the clinician and the client, and that is your activity 11. Alright, this was just an introduction, a discussion of psychotic disorders. There is so much that I would like to say, but hopefully after today's lecture you have an idea of where these symptoms might come from and what these symptoms might look like. So please let me know if you have any questions about the material or about the activity. Remember that you do have 2 activity drop grades. So if you are happy with the top 10 activities that you have from activities 1 through 10, if you're happy with that grade, then you don't necessarily have to complete activities 11 and 12. But if you're confused about that or you have questions, feel free to contact me and I can let you know whether there would be any benefit to you completing activities 11 and 12. Basically, if you missed an activity or if there was an activity you didn't get full credit on, then there's still points you could earn back with these activities. But even if you've earned full credit on the first 10 activities, you could still submit activity 11 if you would like to, just to help you summarize the information and get some feedback from me. So let me know if you guys need anything or if you have any questions. Otherwise, I will talk to you guys during the next lecture video.